Welcome to the dementia-friendly Prince George's County, the Maryland Northern Sector webinar series for caregivers. Today's topic is a deep dive into the 5 dementias presented by Lindsey Vajpeyi and sponsored by the Prince George's County government and the Department of Family Services. Good evening, everyone, and welcome to the Dementia Friends of America webinar series. We are so glad you are joining us tonight to learn more about dementia awareness and how we can build a more supportive and informed community. My name is Canella, and I am honored on behalf of Dementia Friends of America to be here in our local DFA Northern Prince George's County initiative. Today's session is part of our ongoing effort to increase understanding, reduce stigma, and provide meaningful resources to individuals, caregivers, and professionals impacted by dementia. Before we begin, we want to share an important opportunity. In partnership with the Alzheimer's Foundation of America, we are offering free confidential memory screenings for adults who would like to better understand their cognitive health. These screenings are one-on-one, private, informational, and a caring first step, not a diagnosis. Screenings are available at 15 Crescent Road, Greenbelt, Maryland, starting Tuesday, February 10th from 9 a.m. to 2 p.m. To schedule an appointment, please call Caesar at 240-241-0037 or me, Canella, at 410-575-4058. Early detection and awareness matter, and we encourage you to take advantage of this free service or share with someone who may. We also invite you to for online training. You can learn how dementia affects daily life, improve communication and support skills, and helps create a more inclusive and understanding community. It only takes a short time to complete, and you'll receive a certificate upon completion. You can register at the website dfaamerica.org/becoming a dementia friend. Small actions truly make a big difference.
All right, well, good evening, everyone. Welcome to this Dementia Friendly America Prince George's County webinar. My name is Lindsey Vajpeyi. I'm the Director of Education and Support at Insight Memory Care Center. Insight, go ahead, slide. Thanks, Crystal. I'll be cueing the slide. Sorry, everyone. Insight is a nonprofit organization based in Northern Virginia, and we've been around for over 40 years. Insight's mission is to provide specialized care, support, and education for people living with dementia, their family members, friends, neighbors, professionals, and really anyone who is on this journey. And our vision is the highest quality of life, and we certainly value person-centered care, building connections, and creativity in everything that we do. Next slide. So this evening, we're going to be talking about a deep dive into the 5 dementias, the 5 most common forms of dementia. But it would make sense for us to first start with a bit of terminology. So what is dementia? This is an umbrella term, not a specific disease, and it's a term that's used to describe a loss of cognitive functioning to the extent that it is interfering with a person's daily life. It's not just something that is a bit of a nuisance, a little irritating, a little annoying. It's really when these cognitive changes start impacting everyday life and interfering in someone's ability to be independent with tasks of daily living. The word dementia could reference multiple cognitive domains. There might be changes in attention, executive functioning, like planning, problem solving, sequencing, impulse control. There could be changes in learning and memory, particularly short-term memory. There might be changes in language, perceptual and motor skills, social cognition, or other cognitive changes. And dementia is not a normal part of aging. Now, tonight when we talk about the most common forms of dementia, you'll see that quite often the risk increases as someone gets older, but dementia is not a normal part of aging. It's not something that we should expect for all of us as we get older. It's an umbrella term that references a variety of different medical conditions that contribute to these cognitive changes. Next slide. So a few facts about dementia. Dementia affects more than 55 million people worldwide. There are 10 million new cases diagnosed each year around the world. And in the US alone, there are over 7 million people currently living with Alzheimer's disease, not to mention the other forms of dementia. And we expect that number to grow exponentially. That number will be about 14 million people by the year 2060. There are also a lot of caregivers, unpaid caregivers for any individual living with dementia. So it's estimated that there are nearly 12 million Americans who provide unpaid care for a loved one living with dementia. And more recently, a 2025 study found that the risk of developing dementia after the age of 55 is 42%, which is a significant increase from previous estimates. Next slide. So how is dementia diagnosed? There is no one test, no one brain scan, no one cognitive test or medical test that is going to be a conclusive diagnosis for a specific form of dementia. So typically, if someone is experiencing warning signs of a memory or cognitive problem, maybe asking the same questions over and over again, sharing the same stories over and over, forgetting about recent information, important information, having trouble with word finding, having trouble with some of the more complex tasks of daily life, like cooking, using technology, staying on top of the bills, when there are significant changes in judgment, like falling victim to scam after scam, when there are significant changes in mood and personality. These are all potential warning signs of a brain change. So if there are warning signs in yourself or in someone that you know and love, a good first step is to visit with the primary care doctor. That's the person who's going to do things like review the current medications, see if this is potentially a side effect or an interaction. They'll do some blood work, they'll ask a lot of questions, they'll ideally know the patient and kind of know what's normal for them and what's not, and be able to kind of start the ball rolling. And sometimes there's a referral made to a specialist called a neurologist who can really hone in on the diagnosis to differentiate the diagnosis, which means to find out what form of dementia is happening for that person, as well as come up with a treatment plan. So when someone sees the doctor is going to start by reviewing the clinical history. What do they know about this patient, about their family history, about their lifestyle, about previous illnesses or diseases, health conditions, comorbidities, medications, all of these kinds of things. So the doctor is going to get that history. They're usually going to start by excluding other potential causes, other reasons why someone could be experiencing these memory or cognitive changes, but reasons that might be treatable or reversible. So for example, if someone was depressed, depression has a lot of overlapping symptoms with dementia. So if that depression was identified and treated appropriately, the cognitive impairment may go away. It could be a vitamin deficiency, an infection, a metabolic issue like blood sugar changes, a brain tumor. There's a lot of different things that it could be. So that's usually what a primary care doctor is going to start doing. It's kind of going through this list of the potential and potentially making like changes to medications, ordering more testing, asking more questions. Ideally, there is a family member or friend who knows the person well at this doctor's appointment with them. Because often a family member or friend may have extra information, may have examples to share, may have concerns that they'd like to raise with the physician. Sometimes when a person's brain is changing, they're not always aware of the way, the sort of the symptoms that they're experiencing due to the way that the brain lets them process what's happening within. Or if there's memory loss, the person may not remember some of the unusual things that have been happening in their life. So the doctor will be working on excluding other causes. The doctor may order neuropsychological testing, which is in-depth cognitive testing. It often takes 3 or 4 hours, a solid half day of a variety of different kinds of cognitive tests that help a provider understand what's going on in different areas of cognition. You know, really what's going well, where are some of the concerns, what would be typical of a person at that age and education level. So there would be there's a report that would come from the neuropsychological cognitive testing. It's really helpful for a physician to review. There may be neuroimaging, different kinds of brain scans, CT scans, maybe an MRI or a PET scan, depending on what the physician was trying to rule in or rule out. There would likely be some lab testing like blood work, possibly CSF, which is cerebrospinal fluid draw. That's less likely, but possible. And there might be genetic testing. And this is another thing that would probably be less likely, but a possibility in the diagnostic process. So as you can see, there's no one test. It's really like a physician is a detective, and they're collecting all of these clues, putting them together to help rule in or rule out what might be going on. So often when someone goes to the doctor, you know, the first sort of diagnosis, the first terms that they hear for these cognitive changes are dementia. Over time, with additional testing, additional observation, maybe going to see a specialist, the doctor would hopefully eventually be able to see what is causing that dementia, what specific disease is happening in that person's brain to cause these dementia symptoms. So dementia is often the term that's heard first because we're just sort of narrowing, like, yes, something is going on, and it may take an additional many visits, could be an additional year to 2 years to really understand what type of dementia is occurring. So if you'll go to the next slide, please. All right, and I also forgot to mention we have the chat feature here in GoToWebinar. So if you have any questions as I go along, please enter them into the chat and I will take a look at those at the end. So the top 5 most common forms of dementia that we're going to be reviewing this evening: Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and mixed dementia. Next slide. So the most common form of dementia is Alzheimer's disease. You tend to hear these terms used interchangeably, but they're not actually the same thing. Dementia is an umbrella term. There are many diseases that fall into that category, like Alzheimer's disease. So Alzheimer's disease is a form of dementia, at least when the disease gets to the point that it's significantly interfering with daily life. Alzheimer's is a type of dementia. Not all dementias are the Alzheimer's type, the Alzheimer's pathology. So Alzheimer's disease was first identified in 1906 by Alois Alzheimer. Its hallmark pathologies are these amyloid plaques and neurofibrillary tangles in the brain. So brain cells, there are millions of brain cells in the brain who are sending these chemical messages to each other all the time. And these amyloid plaques are these proteins that sort of gunk up in between the brain cells. So it's difficult for these signals to get through. The neurofibrillary tangles, or tau, these are these sort of proteins that, that sort of form inside of the brain cell and kill the brain cell from the inside out. So Dr. Alzheimer, when he looked at the brain tissue of the first patient that he knew of that had this condition, after she passed away, he noticed with some silver staining the plaques and the tangles that are now known as the hallmarks of Alzheimer's disease. So Alzheimer's disease is a progressive condition. It will continue to evolve, to get worse over time. It is not reversible. And it's a real disease. It's a real pathology that's going on in the brain. And I think that's really difficult for all of us to understand when a disease like Alzheimer's is in its early stages, because the person may sometimes do things that are concerning, but may sometimes seem pretty normal. And when there's a disease in the brain, it's not like someone having a broken arm where we have like a visual of a change that's happening in that person's body. But when somebody has a disease like Alzheimer's, these sort of biological and chemical changes are happening in the brain. Now, with Alzheimer's disease, some groups of people are more disproportionately affected than others. We know that about 2/3 of people living with Alzheimer's are women, so more women than men. Black Americans are twice as likely to have older Black Americans are twice as likely to have Alzheimer's as older white Americans. Latinos 1.5 times as likely. And people living with Down syndrome are more likely to develop Alzheimer's disease at younger ages than their peers that do not have Down syndrome. So there are some sort of risks that we don't fully understand related to things like sex and race and other health conditions. And when someone has Alzheimer's disease, it can be sporadic, like it happens and we don't know why. There may not be a family history. And sometimes, in much more rare cases, it can be early onset familial autosomal dominant. So this is quite rare. This is when there is a genetic mutation and a very, very strong family history of Alzheimer's disease. And this sort of family history, you would see many people in the family develop Alzheimer's in their 30s and 40s. So very young. You would see siblings and cousins and aunts and uncles and grandparents, lots of people in the family line who develop Alzheimer's at very young ages. So that is not common at all, but it does happen. Next slide, please. So risk factors for Alzheimer's disease. As I mentioned in the beginning, getting older is a risk factor for many types of dementia, and especially for Alzheimer's disease. The typical onset for Alzheimer's would be after the age of 65, and basically your risk just keeps increasing the older that you get. There's no safe age, sort of once you hit a certain age, it means you'll never develop Alzheimer's disease. That is not the case. There can be genetic risk. Now on the slide, I've pointed out a few different genes. The APOE alleles, this is a gene where you have these sort of combinations of APOE, like 2, 3, and 4, these numbers. And these are like at-risk genes. So we all have APOE genes, but depending on which combinations of numbers you have, if you had 2 copies of the APOE4 allele, that would mean that your risk is higher for developing Alzheimer's disease compared to someone who had maybe 3s and 2s. So doesn't mean it's a genetic mutation, doesn't mean someone will definitely have Alzheimer's, but if they do have these APOE, certain like combinations, that could increase their risk. Now that genetic mutation type of Alzheimer's, that would be the APP, the PSEN1 and PSEN2 genes. So again, this is probably not something that most of us would go out and do, is get this genetic testing as part of our diagnostic process. But if a physician was suspecting that there's a family history, they may order this kind of testing to maybe rule in or rule out a disease like Alzheimer's. Or if someone was involved in clinical trials, genetic testing is often a part of clinical trials, or there are new treatments for Alzheimer's disease, which I'll talk about in a few minutes. But the risk factors are really important to determining who might be a candidate for these new treatments and who is not. So other risk factors for Alzheimer's disease would be certain vascular conditions like having heart disease, history of stroke, high blood pressure, hypertension. These are all things that will increase risk for brain diseases like Alzheimer's. Metabolic diseases like being diabetic, and especially when diabetes has been uncontrolled, increases risk for Alzheimer's. Obesity, traumatic brain injury, or like multiple concussions can increase risk. And then we see some associations, some very strong association with things like depression, hearing loss, and modifiable lifestyle risk factors that seem to increase risk for Alzheimer's. So depression, especially untreated depression at midlife, seems to increase risk. Hearing loss. Now, this is something that there's been a lot of research emerging just over the last few years showing that hearing loss that's sort of not been managed or supported does increase risk for cognitive decline with age. And then those modifiable risk factors. This could be things like getting enough physical activity, like exercise, sleeping well, eating well, education level. So some of these sort of things that are relatively within our control throughout our lifetime could, should they not be well managed, could increase risk for Alzheimer's. Next slide, please. So we'll talk a little bit about the stages of Alzheimer's disease, but I will say that no two people are the same. So what I'm going to describe here on this slide, you may have a family member or a friend with Alzheimer's, and you might say, well, that's not really what's happening exactly with my person. So no two people are going to be the same, but just generally, this is sort of the progression of changes that we see when folks live with Alzheimer's disease. So in the earliest stages of the disease, sort of once we're in the dementia part of the disease, not in the like preclinical or mild cognitive impairment stages of the disease. Once we're in the dementia part, in the early dementia part, there would generally be short-term memory loss. So the person may ask you the same questions repeatedly, tell you the same stories, forget about recent events, recent things that have been told to them. So that short-term memory loss, maybe over the things that have happened over the last many days, weeks, months, potentially the last handful of years, tend to be just either difficult to access or just never made it from the working memory into the short-term memory of the brain. In the early stage, it's not uncommon for someone to have some difficulty finding the words that they want to say, just really having a harder time kind of picking out words in their mind. So the person might describe an object if they can't think of the word for it, or they might have kind of a generic word that they use that could describe a variety of objects, like hand me that thing. Well, what is that thing? Is that thing the phone, the glass, the jacket, and sort of having these kind of generic stand-in words. There might be some confusion in the early stage, just sort of difficulty tracking a lot of information, understanding complex information, kind of retaining pieces of information can cause some confusion, and definitely changes in executive functioning. So that's the kind of frontal part of our brain whose job it is to use good judgment, do problem solving, impulse control, kind of planning things out. These are the kinds of things that tend to change in the early stage. So some of the challenges that you see arising in daily life would be difficulty with driving, which requires a lot of executive functioning, a lot of planning, problem solving, other parts of the brain as well, like memory, visual spatial perception. So a lot of things going on there. Driving, managing the household, paying the bills, safely cooking and doing some of the more complex household tasks might start to change in that early stage. Using technology is a big one too, using phones, computers, remote controls, remembering passwords. These tend to be some of the things that change. And then as the disease progresses, it's just sort of gradual over a long period of time, over the course of many years. So gradually, the person would move from that early stage towards the middle stage of the disease. In the middle or moderate stage of the disease, there would be more noticeable confusion, increased confusion, happens more regularly, is more obvious to others around that person. Their memory would be changing further. So in the early stage, maybe someone doesn't really remember the things that happened in the last couple of years very clearly. Now in the middle stage, it might be the last couple of decades are less clear in that person's mind. There may be an increase in wandering, so that person walking to, which could be sort of aimless, as in I see something interesting and I follow it, or could be intentional. I want to go home, even if I am home, it's not the home in my memory that I'm looking for, and that person may be wandering, seeking something that would be unsafe, that the person would not be able to actually find or safely return themselves back home. In the middle stages of the disease, we start to notice the person needing more help with activities of daily living. So this would be things like getting dressed, using the toilet, showering, grooming, maybe getting in and out of bed, and towards the later stages of the disease, difficulty with eating independently. So some of these needs start to become more obvious into the middle stage, and definitely towards the late stage of the disease. So in that middle stage, there really does now there's a continuous need for supervision and frequent need for support or cueing, or some kind of assistance. So early stage, the person might be fairly independent aside from some of these more complex tasks of life. Into the middle stage, it's kind of like, well, we need to have somebody around pretty much all of the time, being there and available and stepping in to help as needed, sort of increasingly so over time. And then into the late stage of the disease. So typically after the person has had this disease for a number of years, by the late stage, the memory is more significantly affected. So even long-term memory may now be affected. For example, the person may not remember that they ever had children or got married or where they went to college, and really in their minds, they may be more accessing those memories from childhood. And in the late stage of the disease, there would be a significant loss in verbal abilities, like the ability to have a conversation, to form words and sentences and understand other people. And in the late stage of the disease, usually full-time care is required. So help is needed with all activities of daily living. So with transferring from a chair or a bed, with eating, with dressing, with showering, all activities of daily living, someone is there and providing assistance. So again, no two people are the same. And as far as like the rate of progression, it's going to vary a lot from person to person. For one person, it might just be over the course of a few years they go through all of these stages. For another person, this might be over the course of more than 20 years. So it really does vary a lot from one individual to another. Next slide, please. So treatments. I kind of created 3 different buckets of treatments here on the screen. One would be medications. So these are things that would be under the direction of a physician, a licensed physician. Cholinesterase inhibitors. These are medications like donepezil, or Aricept is the brand name of that. And there's a couple of others in that same category of drugs that have been around for 20+ years at this point. They're oral medications, and they really just help with the symptoms of Alzheimer's disease. They're not slowing down the disease itself. They're just kind of helping those messages get around in the brain. So the cholinesterase inhibitors are generally used in the early to middle stages of Alzheimer's disease. One cholinesterase inhibitor, not many from that category. NMDA antagonists. There's a medication called memantine or Namenda that is generally used in the middle to late stages of Alzheimer's disease. Again, an oral medication that's really just symptom management. It's not actually changing the progression of the disease. There might be medications for mood that are helpful, like antidepressants. There might be behavioral medications if someone is severely agitated, very distressed or very aggressive. There might be medications utilized to help with some of those changes. We're going to talk more about that at the end of the presentation, but that is one method of treatment. Or potentially medicines to help with things like sleep. Again, this is not like sort of a first line defense. If someone was having a sleep issue, I wouldn't jump right to medications, but it's a tool in the toolbox. So there are now disease modifying therapies that didn't exist 5 years ago. These are infusion immunotherapies. So not an oral medication like a pill. It would be an actual infusion where a person would go to an infusion center on a regular basis. These infusions target and remove the beta amyloid plaques in the brain. So if you recall, I was saying we have all these billions of neurons, and then these plaques sort of gunk up in between the neurons, and the messages can't get through. So what happens with these disease-modifying therapies, like the infusions, is it's pulling those proteins out of the brain. So it's sort of clearing them out. It's not stopping new ones from forming, so it's not stopping the disease, but it's sort of clearing some of that protein away. So it is slowing down the progression of the disease. It is only for people who have Alzheimer's, not another form of dementia, and it's only for people who are in the earliest stages of Alzheimer's disease. There are risks to this treatment, and so there are also a variety of reasons why this would not be an acceptable treatment option for certain individuals. So should you have questions about these infusion therapies for Alzheimer's, your doctor would be the best person to talk with. And if you have a neurologist on your team, probably the neurologist would be the person more likely to be knowledgeable about these treatments, more so than a primary care doctor. And then non-drug interventions. There are so many things that can be done to support the individual living with Alzheimer's disease that have nothing to do with medications or infusions. So cognitive stimulation, keeping our brains active, right? If you don't use it, you lose it, right? It's kind of natural for all of us. If there are tasks that we just stop doing in our daily life, we sort of get rusty at them. And when someone is living with Alzheimer's disease, it's really, really difficult, sometimes impossible, to learn new things. So we're really trying to keep those cognitive skills active as much as possible, not to the point of frustration or like sort of testing or quizzing or memorizing, but really just keeping the brain active in many different ways with many different kinds of activities. And actually conversation is one of the best things that the person, that helps that person in their brain, because in a conversation, there's a lot of speed of processing that has to happen in the brain, which is really wonderful for brain health. Physical exercise is another huge thing that the person with Alzheimer's can engage in to really support their health and brain health, and really for all of us. So physical activity is wonderful. Lifestyle changes, again, things like getting enough sleep, eating relatively healthy foods, staying hydrated, keeping your stress level low. These are, things that are really helpful for the quality of life. Safety improvements. So there might be things that can be adapted at home, or things like no longer driving the car that can help keep the person well when we don't have extra safety concerns that could cause other kinds of issues to arise. And then another really big one is caregiver training and support. So we'll talk more about this later, but making sure that those care partners, like family members and close friends, have the information that they need to understand what their loved one is going through and have strategies to be able to support that person, as well as support for the caregivers, because it's difficult, it's challenging, it's hard work, it's stressful, it can be sad. And so developing this kind of support team or having people who are a source of support helps that caregiver to stay well so that they can support the individual that they're caring for. All right, next slide, please. All right, so that was Alzheimer's disease, most common form of dementia. The next most common form of dementia by sort of sheer numbers of people experiencing it would be vascular dementia. Now, vascular dementia occurs when there are like these little brain injuries, like microscopic bleeding in the brain, like a hemorrhagic stroke, or when there's a blood vessel blockage in the brain, like an ischemic stroke. So when there are these different kinds of bleedings or blockages in the brain, when that happens, it deprives brain cells of oxygen and it damages those brain cells, and eventually those brain cells die. So the symptoms vary a lot, really, really a lot from person to person, because it depends where those strokes or those bleeding episodes have been in the brain, how many there have been, the size of these injuries, whether it's sort of a massive stroke or it's a lot of little mini strokes that occur over a long period of time. All of these factors really influence what those symptoms are, how significant the symptoms are, both cognitively and potentially physically when there's been a stroke. So with vascular dementia, the progression looks different than Alzheimer's disease. With Alzheimer's, it's just kind of like this gradual, slow progression over a long period of time. With vascular dementia, it's going to be more like stair steps. So you're right here, and then you have a vascular incident like a stroke, and now you're here, and you sort of stay there until there's another vascular incident, and then you're kind of knocked down a peg again. So it's more of a stepwise pattern as far as the changes when someone has vascular dementia. Next slide, please. So risk factors for vascular dementia. Age is another risk factor. Typically, this would occur after the age of 60. If someone has AFib, that can be a contributing factor. Diabetes, especially when it's not been managed well. All of those vascular issues like heart disease, high blood pressure, high cholesterol, history of stroke is going to increase risk. If someone is a smoker, that increases their risk for vascular dementia. And then there are a couple of like much more rare types that happen that are due to a genetic mutation that cause certain types of vascular dementia. Again, very rare, but I just mentioned them here on the slides, CADASIL and CARASIL. Next slide, please. All right, and prevention. The best way to treat vascular dementia is to prevent further vascular issues from occurring. So a few of the things that are sort of top of mind would be to lose weight if someone is overweight, to stop smoking, really, really important to stop smoking, and then to control those different sorts of hearts and vascular issues like hypertension, high cholesterol, diabetes. Seeing a qualified physician, staying on top of any prescribed medications, diet, exercise, things like that can help prevent the risk for further vascular issues. Next slide. All right, the third most common type of dementia, it would be Lewy body dementia. Now, Lewy body dementia is progressive, it's irreversible, like Alzheimer's disease. But in Lewy body dementia, it's a different kind of protein that forms in a different place in the brain. So in Lewy body dementia, of course, these proteins are named for Dr. Lewy. So these abnormal deposits of a protein that's called alpha-synuclein, so Lewy bodies, but alpha-synuclein that form in the brain. Now with Lewy body dementia, there's two forms. I think of them like 2 points on a spectrum. You have dementia with Lewy bodies, which is more of a cognitive dysfunction that might come with some movement features, or you have Parkinson's disease dementia, where someone has Parkinson's disease, usually for many years, which is a movement disorder, and eventually that disease starts to affect cognition. So we've got one end, dementia with Lewy bodies, it's more about cognitive dysfunction. Parkinson's disease dementia, where it's first movement and then cognition. So these are just kind of like 2 points on a spectrum, and sort of together we call that Lewy body dementia. So risk for Lewy body dementia, typically this would be age 50 and over, so potentially a little bit younger than Alzheimer's disease or vascular dementia. Lewy body dementia affects slightly more men than women, not significant, but somewhat more men than women. Sometimes there's a genetic risk for Lewy body dementia as well. And especially just having a family history of some kind of brain disorders seems to increase risk for other types of dementia. We're going to talk a little bit more about some of that in a few minutes. But next slide, please. Let's talk a little bit about the symptoms of Lewy body dementia, because they can be very different than Alzheimer's disease. So there might be cognitive symptoms of Lewy body dementia. And these are the things, especially with dementia with Lewy bodies, that we tend to see early in the disease process. So cognitive fluctuations, where it's kind of like a roller coaster, where someone seems very kind of lucid, normal, high functioning, and then may very suddenly be struggling with cognition, might be very confused, paranoid, just really having difficulty. And without a lot of reason, like why is it sort of going like this? Why do we have these good moments and these confused moments? Where do they come from? And some of that fluctuation is very common with Lewy body dementia. Hallucinations are more common with Lewy body dementia than with other forms of dementia. A hallucination is when someone, truly thinks that they see or hear or feel something that's not there. So this would be like if in this room I really thought that my sister was sitting next to me. There's no one here, there's nothing that looks like a person, but if I thought my sister was sitting right here next to me, that would be a visual hallucination. Or if I thought that the radio was on so loud, oh, someone turn it off, and there's nothing there, that would be an auditory hallucination. Or thinking that I feel something on my skin that's not there would be tactile, right? So this is when there's truly like this feeling or perception that something is there that is not. That's a hallucination, which is different than a delusion. A delusion is sort of a false belief, like I think you stole my purse, or I think that my spouse is cheating on me. That would be more of a delusion rather than like an in the moment seeing something that's not there. Okay, cognitive symptoms, executive functioning. We've talked a bit about executive functioning, the frontal lobe of the brain, things like problem solving and planning and impulse control and using good judgment. These are some of the things that tend to change early with Lewy body dementia. And there might be other cognitive changes. There may or may not be memory changes. There might be some kind of visual spatial perception changes. There could be other kinds of cognitive changes as well. There may be movement symptoms in Lewy body dementia, shuffling walk, challenges with balance, maybe kind of a soft voice for someone who previously did not have that very soft voice, a slowness of movement, possibly a tremor, possibly kind of leaning, some other movement related features, swallowing challenges. There might be sleep-related changes and symptoms in Lewy body dementia. So REM sleep behavior disorder. This is when someone is asleep, but they are acting out their dreams, right? So if I was asleep and I dreamt that I was riding a horse, I might be sitting up in bed, actually like sort of acting out riding a horse, but I'm asleep. I'm not aware that I'm doing that, right? So REM sleep behavior disorder is a really common symptom with someone who has Lewy body dementia, restless leg syndrome, excessive daytime sleepiness, or insomnia could be symptoms as well. There could be mood and behavior symptoms with Lewy body, including things like depression, apathy, delusions, or other kinds of mood changes. And there might also be changes with the autonomic nervous system. So having a lot of difficulty like regulating blood pressure, like it might just kind of like drop all of a sudden, for no real reason that can be identified, or fluctuations in body temperature, someone who's really hot and then really cold when there hasn't been a significant change in the air temperature around them. Frequent falls, which sort of is a combination of the autonomic nervous system, like the blood pressure issues, with some of the movement features like balance changes. A poor sense of smell. If someone has Lewy body dementia, lots of folks report that they actually lost their sense of smell years before they ever had any other symptoms. There's lots of reasons why you could lose your sense of smell, so no one needs to panic right now, but that is something that tends to be pretty common for folks who have Lewy body dementia, as well as other potential autonomic nervous system issues. So we see like a wide variety of different symptoms of Lewy body dementia that are quite different than the initial symptoms of Alzheimer's disease. Next slide, please. All right, so moving on to our fourth form of dementia. Again, if you have any questions, go ahead and put those in the chat. I'm happy to answer them at the end. So frontal temporal dementia. This is a little family of dementias in and of itself. So frontal sort of stands for like the frontal lobe of the brain. Temporal would be the temporal lobe of the brain. So these are a family of dementias that tend to affect those two main parts of the brain. So the most common form of frontal temporal dementia we call FTD. So I'm going to call it FTD for short. The most common type of FTD is behavior variant FTD. So the changes are right here in the frontal lobe of the brain. There would be changes in personality that are just different from what would be normal for that individual or sort of typical of that individual. Changes in behavior, the way that the person acts, the way that they interact with other people, the way that they perceive emotions of other people. Like it may look like the person is less empathetic than they used to be, and changes in judgment, kind of making good decisions. And typically in behavior variant FTD, the person is also experiencing something called anosognosia, which means that they don't recognize the illness within. So it's really common with FTD, with behavior variant FTD especially, that the person just cannot see this illness within, no matter how much proof is provided, the doctor says it, the family says it, everybody's trying to help the person kind of recognize it, and it might be that their brain just does not let them see it. So the term for that is anosognosia. Primary progressive aphasia is another type of FTD that has 3 subtypes in and of itself. When someone has primary progressive aphasia, we know that there is a significant change in their ability to use language. So with semantic PPA, the person usually has difficulty understanding other people. So they may be able to speak fluently, but they're not able to understand single words that the other person might say. Agrammatic PPA, the person is sort of missing little parts of speech. And with lopogenic PPA, that person is having difficulty with word finding and expressing themselves. So they may understand other people, they can comprehend what others say, but they have a lot of difficulty, sort of thinking of the word and expressing the words that they want to say. So people with PPA may experience either like the receptive communication challenges or the expressive challenges, or both. And when someone has behavior variant FTD, often some of the kind of secondary symptoms that they start to experience might be language-based, or if someone is having primary progressive aphasia, there may be some of these kind of frontal lobe changes happening, kind of shortly down the line as well as changes can be going on in other parts of the brain, just like all of these neurodegenerative diseases. And then there are some even more kind of rare subtypes to FTD that are more kind of movement-based. So cortical basal syndrome, where there's this kind of gradual loss of ability to control movement, or progressive supranuclear palsy, where there's a lot of problems with balance and coordination. See the screen kind of moving around. And then there are a couple of even more rare movement-based types of FTD, one that is an FTD with Parkinsonism, and then another that is FTD that is related to ALS. And that form of FTD tends to progress much more rapidly than the others. So this is very complicated. This is very specific subtypes, but generally there are these changes in neurons. Neurons are dying in the brain, and depending on kind of what part of the brain, that is what influences the types of symptoms that we see externally. The next slide, please. So some of the causes and treatments of FTD, well, the short bullet here is that the cause is unknown. Again, like other forms of dementia, there might be kind of a genetic component to some of the subtypes of FTD for some people. Like if there's somebody in the, someone or multiple people in the family who have a history of some kind of cognitive disorder, brain changes, they may be more likely to develop FTD. When someone has FTD, there's a loss of neurons and abnormal amounts or forms of the proteins tau and TDP43. Now, we all have tau proteins in our brain and in our body, and TDP43, so it's not unusual to have these or unhealthy to have these, but this is just when there seems to be like brain cells are dying, or there's just kind of these abnormal proteins that start to build up in the brain. And honestly, it's very complicated, and we don't really know why it's happening. We know even less about FTD than we do about Alzheimer's disease. So there also are a lot of kind of overlap So the person might have changes in their brain that are associated with multiple forms of dementia. So the person may seem to have this lopogenic PPA, like where they have a lot of difficulty with expressing themselves, like putting sentences together and saying them. But they might also have a lot of beta amyloid plaques in their brain, which are a hallmark of Alzheimer's disease. So does lopogenic PPA fit with FTD? Is it an atypical type of Alzheimer's disease? There's a lot we don't know, right? And different providers are going to have different ways that they explain this and understand this. But the truth is, it's just kind of messy. And then the treatments are generally for symptoms when someone has FTD. There's no cure or disease modifying treatment for all these forms of FTD. So treatment, depending on the type of FTD, like with a behavior variant FTD, it might be something like an antidepressant that is most helpful for that person's mood. And for other types of FTD, just really depends on the symptoms that the person is experiencing and trying to manage those symptoms. And then the non-pharmacological approaches are huge, especially with a disease like FTD. So what are all the things that we can do as caregivers, family members, friends to support that person, to keep them safe, to keep them engaged, to keep the quality of life as high as possible, and well, we'll talk a little bit more about that in a minute. So we'll go on to the next slide. Now, one thing I didn't say about FTD as well is it tends to affect people younger than other forms of dementia. So, really between like 45 and 65, especially in someone's 50s and 60s, it's really common to have the onset of FTD if the person were to develop FTD. And so when someone's at that stage of their life, they might still be working. They may be the breadwinner of the family. They may have teenagers or young adult children. So just the dynamics of the disease may feel different in different stage of life, different set of circumstances than when it's an older person who may have Alzheimer's disease. So the fifth form of dementia that we're going to talk about today will be pretty short and sweet. It's mixed dementia. And this just means that somebody has two or more kinds of dementia happening at the same time. So also called multiple etiology dementias. Most often, this is a combination of Alzheimer's disease and vascular dementia affecting the same person. Most often, this is after the age of 80, so the oldest old that are more at risk for mixed dementia. And it often is associated with a faster decline in cognition than just having one form of dementia independently. But again, we're learning more and more all the time. It's very complex. And so there's a lot of thought out there that mixed dementia is probably even more common than we really realize. So we'll move on to the next slide. So management, what do we do? We've talked a little bit about some medications. We've mentioned a few strategies, but what do we do when someone has dementia? Of course, you want to have a great medical team, have doctors or specialists or therapists or other kinds of providers who can support you, support the person living with these cognitive brain changes. And then beyond having a good medical team and the good kind of medical and clinical care that they provide in your regular daily life outside of that clinic visit, we really want to focus on improving the quality of life for the person living with dementia. That often means that we have to adapt the way we communicate with that individual to make it more successful so that we are communicating important things or just like the bonds of relationships, conversation, love, connection, that we're communicating those things with that person and that we're also adapting and kind of following as the person changes in their communication abilities to us, that we're really doing our best to understand what the person is trying to convey to us. What is it that they need? What do they feel? What are they trying to express as their ability to find words or understand changes over time? It's really helpful to establish a routine with someone living with dementia. doing things at about the same time and about the same order every day. And it doesn't mean that it has to be like by the minute, by the book, no flexibility, but generally getting up around the same time, doing things in the same order in the morning routine, just kind of going to bed around the same time every day, and that getting ready for bed routine. Just having a lot of familiarity helps the person navigate daily life with a bit less confusion, a bit less stress and uncertainty. So even if there's memory loss and the person doesn't remember what to do next, or can't follow a clock and track time and follow a calendar, still having a routine is just sort of this like internal way that we know what comes next and we feel more comfortable with it. And honestly, it's really helpful for caregivers as well, because you don't have to always figure out what comes next. There's a routine. And if there's a different caregiver, a different family member, maybe a professional that steps in, if everyone can follow a similar routine, it really is the least stressful for the individual living with dementia. We want to engage the person in activities that they like, that they find meaningful, that they get joy out of, which could be playing that person's favorite music. Quick tip for you, think about the songs or the artists that person would have loved like in their teenage years, maybe young adult years, maybe childhood, but like teenage years is kind of that sweet spot. So playing music, exercising, going for walks, being with family members or pets or kids, going to day programs, engaging in art, doing some kind of a volunteer project, helping around the house, finding ways to keep the person active and engaged throughout daily life. When someone's engaged in an activity, it helps them have something to focus on that hopefully provides some feeling of like being purposeful and valuable and meaningful, or some joy. If the person is not engaged in an activity, you may find that they are sort of up in their head, and the confusion starts to build and the anxiety starts to build, and that's when things tend to kind of go into a more uncomfortable place for them. And I mentioned exercise, always great for the body, great for the brain, great for mood, all of it. So another part of dementia management is actually caring for the care partner. Do the care partners, like family members or friends like yourself, do you have the information that you need? Education about the diagnosis, about the symptoms, strategies for what to do when challenging situations arise in daily life? Do you have support around you? People who understand what you're going through, who've maybe gone through something similar themselves, who you can speak openly with, who validate you. And respite. Respite means a break for a primary caregiver. So if you care for a loved one at home, 24/7, 365, you need a break at some point, right? You might be feeling a sense of caregiver stress that leads to caregiver burnout, which is not good for the caregiver, and it's not good for the person that they're trying to care for either. So having a break on a regular basis helps that caregiver kind of step away, refresh themselves, come in with a little more energy, a little more patience, taking care of themselves, going to their own doctor's appointments, getting better quality sleep, eating a healthy diet, seeing their friends, things that help fulfill their needs as well. And then planning for the future. When there's a progressive condition, we know things are going to change. There are plans that need to be made sooner rather than later. So things like legal and financial documents are really important to get in place in the very earliest part of the disease, while the person has the legal capacity to sign legal documents about their care, about what they want, or who they want to make decisions about themselves if they couldn't. And then other kinds of plan for care. Are we caring at home, and what does that team look like? What resources are available to support us while we navigate this at home? Or are we considering moving into a senior living community of some kind, like an assisted living, a memory care community? What might that look like? Can we even afford it? Right? Having these conversations to start talking about the future, planning for the future, understanding options and resources. Next slide, please. And none of this is easy. And you're just going to take it step by step, day by day. You have questions, you call someone, you call and ask, you call your area agency on aging, you call us, you call whoever it is that you have access to, and just start asking questions. And one door will open and lead to another, just to navigate with you along the way. And at Insight, we have a variety of programs, including caregiver support groups, education classes, online resources, complimentary consultations. And so you can go to the next slide. And we're always happy to talk with you if you have questions, if you have a need. We are here for you. So check us out at insightmcc.org, or you can give us a call at 703-204-4664 and ask to speak to someone from our education and support team.